Good afternoon, everyone. Uh, Welcome to the session harm reduction of Yaba and Methamphetamine user. This is this session will present in English, but if someone like to got a translation, please take a headset and contact to the officer to get a headset for the translation. My name is Manop Kanato. I'm from Acting Chan Science Center, Wong Charit Kun University, Nakhon Ratchasima. And today, it is an honor to serve as your moderator today. As you may know that Yaba and methamphetamine is a big problem of Thailand for such a long time. And we don't have a clear yet about how we do it regarding harm from this drug. Today we have some experience from expert from 3 people. The first one is Mr. Pascal Tanguay. He's a freelance and working with drug user for many years in Bangkok. So we will see that what he have done for such a long time and what happened. He will tell us about that. The second one is Miss Eleanor Ong. She's a director of the Greenhouse Community Service in Singapore. She will give us some experience about what she has done in Singapore. And unfortunately, the third one, Miss Nguyen Trang from Vietnam, she's not coming, but she sent a video for us already. So I will put her video at the end of the presentation. The first time I like to invite Kun Pascal to present first. Kun Pascal, please, it's your time.
ขอบคุณนะครับ Thank you and good afternoon สวัสดีครับ So my name is Pascal. I'm generally freelance. Today I'm doing work. The work that I'm going to present was conducted by COACT. COACT is a consultancy firm that hires people who use drugs to provide technical support services to organizations to help them improve their harm reduction programs. So in this case, I will present about how pipe distribution for stimulant drug users has helped engagement and mobilization of people who use drugs to better reach them in 3 different countries. So we have experiences from Indonesia, from Kyrgyzstan, and from the United Kingdom. How does this work? Okay, so I'll just give you a brief overview. I'll start by giving you a little bit of background about the situation. Then I'll talk a little bit about the process that we use to conduct our research and obtain our results. Then I'll talk about the results from the 3 projects in Indonesia, Kyrgyzstan, and the United Kingdom. I'll give you some of the conclusions that we were able to draw and some of the recommendations that we hope to promote and publish later this year. So to start, harm reduction, as you probably know, harm reduction generally has focused on meeting the needs of people who inject drugs. People who inject drugs have generally been, again, focused on opiate users, so heroin users especially. So the harm reduction strategy and services recommended by the UN, by other guiding bodies have focused on injecting and opiate users mostly. So addressing the harms of stimulant drug users has been more challenging, and there's limited programming that's being implemented at scale at the present to meet the needs of people who use stimulant drugs. So we focused especially on stimulant users who were smoking drugs, because smoking, although it seems that there might not be so many risks associated with smoking, the reality that just the act of consuming a stimulant drug by smoking, by inhalation, does lead to some significant harms and risks for transmission of bloodborne infections. So I've listed here, for example, that especially in the context of using these improvised pipes or homemade smoking devices, often called street pipes, using those can lead to several types of wounds, cuts, burns, blisters that can facilitate or increase the risk of transmitting bloodborne infections. It can lead to the inhalation of toxins and carcinogens, and it can cause lung injuries like bronchial infections and aspiration of foreign bodies that lodge inside the lungs and can create significant health problems. And these are just the harms that are specifically associated with the act of smoking with these improvised pipes. In addition to that, which I will not go into because I believe this has been covered elsewhere, there are significant harms related to the substance itself that is being consumed. Our project, slide top by our project looked at 3 different countries, and in the 3 countries there were different drugs that were being smoked. So we'll go through that in a moment. Here I put up some images of what those street pipes or improvised pipes look like. This is specifically for methamphetamines. First one? Yeah. Cap and a cap. Okay. Try that. So, going backwards. There we go. So, in terms of, there is evidence that shows that distribution of pipes provides significant positive impact to improve the health and social care of people who use stimulant drugs. A few years ago, there was a very large desk review that was commissioned by the World Health Organization in collaboration with the United Nations Office on Drugs and Crime to look at the evidence for what kind of programming creates what kind of impact for people who use stimulant drugs. So what the desk review found was that, first of all, that the distribution of heat-resistant pipes reduces the risks of wounds, blisters, and cuts for those who use them, and therefore reduce the risk of transmission of all types of viruses, especially bloodborne infections like hepatitis C, but also herpes, COVID-19, flu, and tuberculosis, which are more airborne viruses. Pipes also helped reduced or facilitated the transition from injecting, which is even riskier, to smoking, which reduces some of the risks related to drug use. In parallel, the pipes facilitated or created opportunities to initiate a discussion, and it created a contact or improved the relationship of trust between the client and the service provider. So it created an opportunity to engage and mobilize people who use stimulant drugs more effectively. And following from that enhanced trust, it helped, the distribution of pipes helped increase access to services like testing and treatment especially for HIV. It was especially tested in the context of HIV, and there was a significant increase in access to testing and treatment following pipe distribution. So our process, we identified at COACT, we identified 3 different projects that were distributing these safe pipes or safe smoking kits to people who use stimulant drugs to help promote that approach. Pipe distribution is very much akin to needle and syringe distribution for injectors in that providing them with safe, clean using equipment will reduce risks. They won't need to share and therefore reduces the risk of transmission and reduces all sorts of all the other health harms that I already mentioned. So in Indonesia, we identified the organization Charisma, funded by the Mainline Foundation in the Netherlands. In Kyrgyzstan, we worked with the AFU, with the AIDS Foundation East-West, that was funded by the Elton John Foundation. And in the UK, we worked with the London School of Hygiene and Tropical Medicine that was funded through the National Institute for Health and Care Research. We collected our data, the data that I'm going to present today, or the results I'm going to present today, we collected them through a series of key informant interviews, especially for Indonesia and Kyrgyzstan, that were also validated through an extensive desk review for the two countries. For the UK, our team was involved in the implementation of the study. It was a study project, a research-based project. So we were directly involved, so we had access to the results. So very few interviews were conducted to get the results from them. In Indonesia, the project managed by Charisma focused on methamphetamine users. Specifically, it was a pilot project that was initiated to provide people with the information, skills necessary to facilitate better access to healthcare services. The project lasted 5 years. They mobilized a team of 11 paid staff and 17 volunteers to act as peer outreach workers to engage with people who use drugs in the community and distribute the pipes. As part of this project, there were annual needs assessments that were conducted in the 25 districts in and around Jakarta to identify the needs of people who use drugs and adjust the project accordingly. So the project was very dynamic and led to many changes of direction along the way to improve the results. So between 2016 and 2020, a total of about 5,500 people who use methamphetamines were reached by the project, some up to 16 times per month with services. And I've given you a breakdown of those 5,500 people based on, so most were men, there were 600, a little over 600 women, a little over 450 men who have sex with men, about 100 female sex workers, and just a little over 20 transgender women. That was a big challenge for the project team to operate beyond the traditional stimulant drug users and gain access to more gendered communities. Was a big challenge for them. So the pipes that were distributed were initiated only in 2017. So initially the project did not include the pipe distribution component. This was added later as there was significant requests from the clients to have access to those pipes. Pipes in Indonesia are illegal. People who possess them can be arrested for possession of drug paraphernalia. So even for the project to secure and procure the pipes was an important challenge that required significant advocacy from the community-based organizations in collaboration with the police and with the Ministry of Health. Ultimately, in 2019, they were able to in 2017, they were able to procure the pipes, and that was packaged in a safe smoking kit that included a branded lighter, aluminum foil, straws, and an IEC leaflet, so information, education, and communication materials to help people take better care of themselves. It was only in 2019 that the pipes were added to the kit, which took some time to identify where to procure and how to procure those safely. And as part of the project, between 2019 and 2021, a total of 1,200 of these glass pipes were distributed to the clients. In Kyrgyzstan, the project was slightly different, and this was an online outreach project targeting, again, people who use stimulant drugs. In that target population, the most commonly used stimulant drug is a new psychoactive substance called alpha PVP, which models very much the effects of methamphetamines, and mephedrone. So the idea was to also ultimately facilitate access to low-threshold anonymous healthcare services. As part of the project, they were able to distribute over 2,600 harm reduction kits to about 2,500 unique clients, with 84 of them receiving repeated services over 6 months. Many of the clients who were reached by the project, the kit included self-testing for HIV. So many of the clients who received the self-testing kit ultimately preferred to be tested under the supervision of a peer outreach worker. And also about 4/5 of the clients engaged online, but ultimately wanted to meet face-to-face with the peer outreach worker, especially to access the harm reduction commodities that the project provided. So in Kyrgyzstan, the safe smoking kit included HIV self-testing kit with an oral fluid test, condoms and lubricants, glass pipes, vitamin C and rehydration supplements, as well as chewing gum and stress relief items to reduce cravings and help with the come down from stimulant drugs. In the UK, the project was, again, slightly different. This project was, as I mentioned, a research study that was conducted through a university. So the project was implemented at 3 sites in England with an additional 3 control sites targeting people who smoke crack. So the project included the participatory design phase, an implementation phase, and an evaluation phase. The research study is completed, but the data is still being analyzed. So what I'll present here is preliminary results that have been validated by the principal investigator, but is not yet published data. The data from this project, from this study, should be released later in 2025. As part of the SIP project, they were able to distribute over 3,300 kits over a 6-month period. Approximately 180 people who received the kit said that this was the first time that they had ever accessed any kind of drug treatment or harm reduction service regarding their drug use. Out of those 180, the vast majority specifically accessed the service because of the promise of a harm reduction kit, because they wanted access to the pipes. The SIP kits there's an image of the SIP kit here. So it contained a Pyrex glass pipe. So Pyrex is a type of glass that doesn't heat up. So it's very safe for smoking because you don't end up burning your lips. So the Pyrex pipes included also brass gauze to act as a filter, or can't remember the exact term, but a suspension medium to hold the crack as it is heated with a flame. As well as rubber mouthpieces to protect the lips, and a wooden push stick in a plastic case to free up the pipe after its use. So those were supplied mostly through drug treatment services, 1 sex worker service, and 2 peer outreach networks. In the context of this project, as it was done in Indonesia and in Kyrgyzstan, peer engagement was absolutely critical to facilitating effective distribution of the kits and building that relationship of trust with the client to facilitate access to onward health services. So compared to other recruitment or distribution channels, the peers were better able to access clients who were considerably more vulnerable, so who had more layers of vulnerability, who were, for example, homeless or had other underlying health issues, as well as to facilitate, they were better able to facilitate access to health services. So a higher proportion of clients who accessed pipes through peers were more likely to end up accessing additional health services after they had received the pipes from a peer, compared to a medical doctor or another health facility. So in conclusion, the 3 projects in the 3 countries were all quite successful. They were, in many ways, all 3 of them were pilots. This was the first time, to our knowledge, that pipes were being distributed to people who use stimulant drugs. In all 3 projects, like I just mentioned, peers were absolutely critical to engaging with clients, to identifying where they are, and facilitating their engagement with the services, and then distributing the commodities necessary for improving their health. Peers helped recruit people who use stimulant drugs who were not previously in contact with health services. So again, this is very important because, as I mentioned at the very beginning, our harm reduction service approaches tend to focus on injectors and opiate users, and stimulant drug users are considerably more difficult to find and to access and to bring into the fold of the health services. So pipes distributed by peers significantly improved access and mobilization of clients. And lastly, all 3 projects identified a clear need to integrate mental health services as part of harm reduction services for people who use stimulant drugs. So out of the 3 projects, we were able to come up with a set of 7 recommendations that, again, we hope to publish in a separate report summarizing the 3 experiences from the 3 countries before the end of this year. So I'll briefly go through the recommendations. So the first one is to ensure that Pyrex pipes should be distributed to people who use stimulant drugs to improve their health outcomes. Number 2, that those pipes should be part of a comprehensive package or a comprehensive kit that includes additional commodities to, again, facilitate engagement and to improve attractiveness for the clients. Pipes and safer smoking kits there should be significant effort to target people from the LGBT community, as well as men who have sex with men, and people who engage in chemsex to reduce risks and improve health outcomes. Peers should always be the front line, on the front lines to engage with people who use stimulant drugs to facilitate their entry into the healthcare system. Web outreach and e-learning should be a complement to community-based approaches and strategies to find and engage and retain people who use drugs or people who use stimulant drugs. We also found that drug checking services, so having reagents to assess the potency and the purity of drugs, to be made accessible at drop-in centers or at service access points, would also increase demand for harm reduction services for people who use stimulant drugs. And finally, as I mentioned in the conclusion, mental health services need to be more integrated and better integrated in the comprehensive package of health and social care services targeting people who use stimulant drugs. Thank you very much.
Thank you, Kun Pascal, for your valuable presentation. Our second speaker is Miss Eleanor Ong from Singapore. Miss Eleanor, the floor is yours.
Thank you. Good afternoon, everyone. My name is Eleanor. I'm a PhD candidate at the Salisbury Hawk School of Public Health at the National University of Singapore, as well as the director of the Greenhouse Community Services. And I feel very privileged to be able to share with you our work in community-based harm reduction services for methamphetamine in Singapore. As a past methamphetamine user, it's also particularly special that today is my 11 years not using methamphetamine. So it's quite a unique situation that I'm in today to be able to share with you. The presentation will explore how we've adapted harm reduction principles within Singapore's unique policy environment and the lessons we've learned that may be applicable to other communities facing similar challenges. So just really quickly, I'm sure most of you might be familiar with some of this already, but let's begin by establishing what we mean by harm reduction. So harm reduction is fundamentally a public health approach to psychoactive substances, including alcohol, cannabis, and other substances, and drug policy. What makes harm reduction unique is that there is no universal definition or formula for implementing it, but it must be adapted to local contexts, cultures, and policy environments. So the key principle that guides all harm reduction work is this: a person's drug use is actually secondary to the harms associated with that use. This means we focus on reducing the negative consequences of drug use rather than solely on eliminating the drug itself. So this approach recognizes that people may continue to use substances for various reasons, and our priority should be minimizing the health, social, and economic harms that can result. So why does harm reduction matter? The evidence shows us six key areas where harm reduction creates positive impact. So the first is health outcomes. Harm reduction significantly reduces transmission, overdose death, and other medical complications. Secondly, it's practical and realistic. Harm reduction acknowledges that abstinence-only policies often fail because they don't account for the complex realities that people face, such as trauma, mental health issues, poverty, and social isolation. In this way, harm reduction is realistic as it meets people where they are, making interventions more likely to be accepted and effective. And it recognizes that incremental progress towards safety is valuable, even when complete behavior change isn't immediately possible. It's also cost-effective. Preventing infections, overdoses, and hospitalizations through harm reduction programs cost far less than treating these conditions after they occur. And the medical expenses avoided through programs like needle exchanges and opioid substitution therapy generate substantial healthcare savings. So it also builds trust and engagement. So harm reduction creates opportunities for meaningful relationships between service providers and vulnerable populations, as Pascal has also mentioned. This trust often becomes a pathway to additional services like addiction treatment, housing assistance, and healthcare, including mental health care. It also reduces stigma, so harm reduction challenges the moral framework that can often surround risky behaviors, treating them as health issues rather than character flaws. And this shift in perspective can reduce the shame and isolation that often worsens underlying problems. And last but definitely not least, community safety. Safer practices reduce risks, not just for individuals, but for entire communities. Now I'm going to talk a little bit about Singapore's approach to drugs, which creates a unique context for our work. So Singapore actually has a zero tolerance policy or approach to drug use, emphasizing what they call harm prevention rather than harm reduction. So Singapore is about preventing drug use before it can occur by tackling both drug demand and supply with the aim of building a drug-free society. So this approach in Singapore is coordinated by the Central Narcotics Bureau and the Ministry of Home Affairs that oversees national security, as opposed to another ministry such as the Ministry of Health, for example. So it's important to understand this context because I think it significantly shapes how harm reduction services can actually realistically operate in Singapore. Drug policy in Singapore has four main pillars. There is preventive drug education in schools and national campaigns. There are tough anti-drug laws and enforcement. Most drug abusers are sent to Drug Rehabilitation Center, which is operated by the Singapore Prison Service. And there's some rehabilitation aftercare for those who use drugs, such as home detention and halfway houses. There are also severe penalties for traffickers, including the death penalty. So this year, the state has already executed 4 people based on drug-related offenses, and last year we executed 8 people based on drug-related offenses, which is, to me, very upsetting, and it's like a really huge human rights issue, and particularly because most of those executed belong to low-level, they were actually low-level drug couriers. So while there's been a multi-pronged approach in Singapore to address the the drug situation in Singapore, there are significant gaps in the care continuum that leave many people without adequate support. So, for example, if people go to jail, when individuals don't find appropriate help, they may eventually end up being incarcerated and separated from family and community. And while community services exist, there are barriers to help seeking due to the fear of arrest or stigma. And additionally, social workers may not always be trauma-informed or LGBTQ plus affirming, which is crucial for many of our clients at the greenhouse. Private treatment is, of course, available. However, the cost is often prohibitive for most individuals, particularly our clients, and it makes it a non-viable long-term option for the populations that we serve. So just a side note that in Singapore, even if you come forward to a medical doctor to seek treatment for substance use, the doctors are mandated to report this to the Central Narcotics Bureau, which then causes a lot of issues and a lot of fear for people to come forward, even if they do want to stop using drugs. So the gap here, perhaps more critically, is that there is no safe, accessible place for individuals who wish to stop using, but need to receive care and find community affordably. So this gap in affordable, accessible, and culturally competent care is where the greenhouse steps in. So the greenhouse was founded in 2017 as a non-profit registered charity in Singapore. Our founder, Elric Tan, decided to start the greenhouse because of his own lived experience of struggling with abuse, depression, guilt over his sexual orientation, and eventually substance use, which led to incarceration. So our origins are rooted in the philosophy of nothing about us without us, meaning that those with lived experiences must be central to designing and delivering services. So we bring mental health treatment standards at no cost to those who face additional barriers to care, deliver in a holistic and integrated manner. We recognize that the people we serve face multiple intersecting challenges, not just substance use, but very often trauma, mental health issues, discrimination, poverty, and social isolation. Our mission is to provide a safe and supportive space for individuals recovering from substance addiction, especially those from marginalized and vulnerable communities. And while there is a focus on persons, on LGBTQ individuals, racial minorities, people who are living with HIV, people who have been formerly incarcerated, all are welcome at the greenhouse. This is the greenhouse model of care. So our model addresses 4 dimensions of healing: biological, psychological, social, and spiritual. What is core to our approach is how we frame the journey of recovery as transformation in identity and purpose. So we see people moving through different stages, from drug addict to trauma survivor to wounded healer, and then eventually sort of becoming recovery ambassadors. And this goal is to help clients experience a sense of meaning and purpose through 3 key connections: connecting to the self, connecting with others, and then also connecting with purpose. So this allows them not just to heal from trauma and outgrow addiction, but create a sense of self for lasting recovery through serving others. Our approach then also aligns with Singapore's national priorities. Under the HEAL pillar, we desire to build up resilient individuals, stronger families, and a caring society. With our services, people can be better versions of themselves, connect with loved ones, and give back to society. Under the SERVE pillar, the lessons learned from our center are also relevant for other nationwide issues, such as supporting rough sleepers. Our peer supporters who have lived experience are also great examples of those who have experienced adversity and continue to give back to others. So in my earlier slides, one of the things I mentioned around the benefits of harm reduction is that it is cost effective. And this is some of the compelling data about the economic impact of our work. So per client per year, the greenhouse generates 72,281 Singapore dollars in cost savings to society. So I converted that, so that's about 56,000 US dollars and about 1.8 million baht per person. Per client per year. So that is significant amount of money that investing in harm reduction and recovery support can really transform lives and also make strong economic sense for society. So the core components of the greenhouse, our comprehensive model includes 5 core components that work together to provide holistic and integrated support. We have peer support, individual counseling, community support programs, research and outreach, family and friends program, referral to other services, and additionally, we have an upcoming therapeutic art and horticulture group therapy sessions where we are expanding our healing modalities to include creative and nature-based therapies. So let me run through them one by one. So peer support is the foundation of our model, as very aligned with Pascal's presentation as well. When a client walks through our doors, it begins with an intake assessment conducted by a trained peer supporter who understands the journey from their personal experience. Together with the client, they co-create a care plan that's tailored to individual needs and goals. We offer various peer support activities, including trauma-informed 12-step meetings and community programs. What's crucial is our investment in training for peer supporters. So there is a selection process of peer supporters through clients who are doing well in their recovery, and then providing comprehensive training through workshops, mentorship, and continuing education. And this investment in our people ensures that peer support is not just well-intentioned, but professionally competent and evidence-based. Next, we have our individual counseling, and many of our peer supporters actually choose to then go on and become counselors themselves, which creates a beautiful continuum of growth and giving back. The greenhouse provides structured and rigorous training through our counseling internship program. So we are currently on the 8th run of this program, which is a 9-month intensive program that is closely supervised. The curriculum focuses on building expertise in 4 crucial areas: sexuality, substance use, trauma, and co-occurring disorders. So these are complex issues that our clients face, and our counselors need specialized skills to address them effectively. So this program not only builds local capacity, but also ensures that our therapeutic services are culturally relevant and trauma-informed. Our work also extends beyond direct service delivery. So we also have run workshops in collaboration with the Ministry of Social and Family Development in supporting marginalized and vulnerable communities with diverse needs. And this helps to build capacity across the social service sector. We also conduct outreach and education sessions to reduce stigma and increase understanding about substance use and recovery in the broader community. Additionally, we present our research at academic conferences, contributing to the global knowledge base on harm reduction and recovery services. So our work is only possible through extensive collaboration. What we cannot do alone, we can definitely do together. We work with both government and non-government agencies to conduct our research, outreach, education, and training activities. And these partnerships also help us navigate Singapore's complex policy environment while maintaining our commitment to harm reduction principles. Recovery also doesn't happen in isolation, so it happens within relationships and communities. So our Family and Friends program recognizes that addiction affects entire relational systems, and healing must include these important relationships. The program has 3 components, so a comprehensive assessment and support planning that looks at family dynamics and relationship patterns, ongoing peer support through monthly group meetings where members can connect with each other facing similar challenges, and individual counseling for personalized care. We recognize that also that no single organization can meet all needs, so referral to specialized services is crucial. We maintain partnerships to provide 3 key types of referrals. So there is legal support services for clients who are navigating legal issues that may arise from their substance use, specialized counseling services for complex cases when clients need expertise beyond what we can provide in-house, such as specialized trauma therapy or psychiatric care, health screening, and medical partnerships, ensuring clients receive competent and comprehensive healthcare, including treatment for co-occurring medical conditions. So our role is often to serve as a bridge, helping clients access these services and advocating for their needs within systems that may not always be welcoming. To truly understand how our different programs work together, I encourage you to scan the QR code at a later time to watch our recent feature on Channels News Asia's Extraordinary People program. This feature includes real stories from our clients and shows the day-to-day reality of our work. And most importantly, it is a powerful demonstration of recovery and resilience that goes beyond what any presentation can convey. So I'll just give a minute for people who want to take a photo. So I'm going to be candid about the challenges that we face and how we address them within Singapore's context. So stigma and discrimination, this is a global barrier for persons who use drugs, but it's particularly acute in Singapore due to the legal context. This stigma is compounded for our key populations, including LGBTQ persons and people living with HIV. So legal and policy barriers. While 34 countries globally retain the death penalty for drugs, Singapore's punitive laws do limit the scope of harm reduction work that we can actually do. So most of our work needs to be abstinence focused, though we maintain harm reduction principles, or we try our best to retain and maintain harm reduction principles in our approach. Like many other harm reduction organizations, we face resource constraints and funding challenges. As a small nonprofit, we're reliant on donations and volunteers at the greenhouse. And at this point, the greenhouse functions with only 4 full-time paid staff. Other challenges involve addressing trauma and mental health. Many of our clients are trauma survivors requiring complex and integrated support. This also requires specialized skills and approaches and often requires longer-term care. And the last one is sustaining motivation and recovery. Relapse risk and burnout are common globally. And some clients struggle with long-term motivation, which is why we use a cyclical model, which welcomes people back without judgment. Despite these challenges, we're seeing positive changes in how communities approach harm reduction, and this happens through 2 main areas. First, community-based initiatives. We're creating safe and inclusive spaces that reduce harm, even within challenging policy contexts. We're building local partnerships to deliver trauma-informed peer-led services that fill critical gaps, and we're strengthening community engagement through active family involvement and robust volunteer networks. Secondly, regional forums and networks such as this one allow us to foster multi-stakeholder collaboration, and this allows for a coming together of NGOs, civil society, government agencies, and practitioners to share best practices and address emerging drug trends. So we are facilitating cross-framework learning and exchanging experiences across different legal environments to adapt harm reduction strategies through evidence-based research and proven approaches. What have we learned about what makes harm reduction work even in challenging environments? Firstly, that collaboration, resilience, and community engagement reflect core global harm reduction values. These principles are universal, even when specific interventions must be adapted. Second, we need adaptable strategies that work across diverse policy environments. What works in one country may not always be legally possible in another, but underlying principles of dignity, respect, and meeting people where they are at remain constant. Third, evidence-based approaches strengthened through regional partnerships are essential, and we can't work in isolation because we need to learn from each other and share what works to build this evidence base together. The work of harm reduction is very challenging, but it's also deeply rewarding. Our work at the greenhouse shows that even within restrictive policy environments, it's possible to provide compassionate, effective harm reduction services. The key is adaptation, collaboration, and never losing sight of the fundamental dignity of every person that we serve. If you'd like to learn more about the work that we do or would like to collaborate, this is my contact details, and the QR code is the link to the greenhouse website. Thank you for your attention.
Thank you, Ms. Ong, for your community center perspective. Our final speaker is Ms. Nguyen Minh Trang from Vietnam. We will see her from the video.
Harm reduction and addiction treatment at SCDI, a local NGO in Vietnam focusing on improving quality of life of the vulnerable and marginalized populations, including people who use drugs, people living with HIV, LGBTIQ communities. It's our honor to be invited to speak at this very timely, very important conference on YABA, methamphetamine, and synthetic drugs. We are here to share with you the community-based multidimensional model of interventions for people who use stimulant drugs in Vietnam that ACDI is implementing in 7 provinces across the country. So as a country in the Southeast Asia region, we also noticed the emerging trend of methamphetamine use in our country as reported by UNODC and other regional agencies. The HIV/AIDS Control Agency in Vietnam also reported an increase in the number of new HIV incidents in our country. As you can see in this graph, it going down and then going up in 2020 and until now. And they also reported a switch from the traditional bloodborne transmission to the sexual transmission, and now sexual transmission accounted for the majority of new HIV incidents in our country. So both of these trends are closely tied with the methamphetamine use happening in our country. So as an organization who work very closely with the community, we know that we have to do something about it. The major program for HIV in Vietnam only target the people who inject drugs. That is a Global Fund project. But people who use methamphetamine and other new synthetic drugs, they don't inject, so they fall out of the major program like that. So because of the needs of the community, we established a project called Saving the Future, where we target young people who use stimulant drugs aged 16 to 24 years old. This is a logical framework of the project that we implemented in 7 provinces in Vietnam. So we see that methamphetamine is associated with HIV infection because of the changing in the behaviors and lifestyle of people who use methamphetamine, including the practicing of unsafe sex, like group sex, gang sex, unprotected sex. But it also affects even for people who adhere to the HIV treatment, methamphetamine use is also reported and studied that it is also associated with the increase in the viral load for people who even adhere to ARV treatment. So it shed a light for ACDI that we don't only address the behaviors, but we also have to support people with treatment adherence when they use methamphetamine. But in other factors associated with methamphetamine use is also mental health disorders. People with mental health disorders also have tendencies to use methamphetamine to address their own issues like depression, anxiety. But people who use methamphetamine also slowly developed the mental health disorders, as we all know it, including the psychosis. And the studies also show that one of the biggest under-addressed issues among people who use drugs is childhood trauma. People with more than 4 adverse childhood experience have the tendencies of engaging in unsafe sex, in developing mental health disorders when they grow up, and drug use. So this is a logical framework that we identify the direct and indirect factors associated with methamphetamine use. And we find that if we only address only the HIV, it will not be enough for people who use methamphetamine. It has to be the interventions for HIV, for harm reduction, for the drug use, and also the adverse childhood experiences and the mental health issues among these populations. And because of that logical framework, we developed the core interventions. As you can see here in the screen, the first component is HIV intervention. The second is harm reduction for drugs. And third is mental health intervention. Fourth is adverse childhood experiences intervention. And on top of all this core intervention is a chemsex package that we developed that doesn't only target the unsafe sexual behaviors, but also the sexual and reproductive health, the mental health, and the physical health of people who practice chemsex. So those are the 5 core interventions that ACDI developed and implemented. When we implement the project in Vietnam, we screen for the risk of each client that we recruit, and we individualize the interventions for them. We use the finger screen scanner so that we each of the clients come to us have a unique number for them. We don't collect their name, we don't collect their personal information, but we identify them when they come to us. We identify them by their code and their fingerprint. For the HIV intervention package, similar to other organizations in the region, we also provide the community-led HIV testing. That the communities are trained to do the counseling for the clients before and after testing, and if the test is active, is positive, we refer them to HIV confirmation test and ARV initiation. We also provide the treatment adherence support by doing the viral load after 6 and 12 months. As I mentioned in the sharing of the logical framework, even for the clients who adhere to the treatment, their viral load can still be high when they are still using methamphetamine. So treatment adherence is a very big component in our program. For the harm reduction interventions, we do the drug screening test just to see the type of drugs that our clients is using. This is a way of monitoring. We ensure safety, and we ensure that no information of the clients can be shared to any other organizations. And we do the ASIS screening, we do the risk behavior screening and counseling for harm reduction for clients. And It is not a diagnostic tool, but the questions are easy enough, simple enough for the outreach workers who are not professionally trained on mental health to be able to deliver the initial thoughts, initial talk of mental health to their clients. We also communicate on the some of the mental health interventions that we do is we communicate about the long-term needs, emotional needs, mental needs of the clients, so that they gradually build their resilience. So we call this community-based mental health interventions because it cannot be too complicated and too complicated for the communities to implement, but it helps, it initiates the talk between the communities and their clients on mental health in the simplest way. For example, this one is a skilling technique where clients, when they come, they are given a scale and they identify their level of emotional state right now. 0 is great, never been better in their life. 100 is complete crap, never been this bad in their life. And the CBO initiates a talk with them on mental health based on the score that the clients is sharing. The next time the clients come, if the score change, they identify that what makes the score change for them, what is worse, what is better, so that they build their resilience, they identify their own emotion and they build resilience based on that. So those are the interventions that we design specifically for our clients that is easy to implement by the outreach workers. Another one is self-soothing, the same thing. What do you like to do when you are on edge, when you are nervous, when you are anxious? If you are not doing drugs, what can you do to soothe yourself when you are feeling on edge like this? So doing something that they like to do, like smelling, hearing, or taste something. So it's very easy to implement. The last intervention that we developed is the adverse childhood experience intervention. Because all of the clients are right now above 18 years old, the childhood trauma already happened to them. We organize the activities so that they can share about those experiences and know that they are not alone in this world. Other people experience the similar things that they do. And by organizing the group-based intervention, like the healing circle, as you can see in this picture, or the art-based therapy, where the clients can draw, can make things with their hands. They express themselves, they express what they're feeling inside toward others without fear of being judged, without fear of being the only one who experiences it. Because as human beings, we experience similar things across our life. And for this group of people, many of them leave the group saying that they feel touched, they feel understood, they feel listened to by people who experience the similar things. This is some of the outcomes that we have achieved so far with our program. We reached a total of more than 10,000 clients in 7 provinces and cities in Vietnam. The first project I share with you is Serving the Future, where we only target the young people from 16 to 24 years old. Later on, we received another funding that helped us to target the people who are above 24 years old. The type of substance use are quite similar among the two groups, but for the group of people who are above 24 years old, the use of heroin or opioids at the same time with methamphetamine is higher. And for the group of people from 16 to 24 years old, they also, majority of them use methamphetamine, but they also use ketamine, ecstasy, and cannabis. And 3 out of 4 of the clients use 2 or more substances. very little number of the clients who only use one type of substance. The first use age, when do people start using drugs? For the group of clients who are above 24 years old, as you can see, the 66%, the majority of them using drugs starting from 19, 25 years old. Meanwhile, when we ask the same questions with a group of clients from 16 to 24 years old, 71% of them started using drugs from 15 to 18 years old. So the group, so we can see that the age to start using drugs is getting younger. HIV status among the clients, the group of above 24 years old has higher HIV incidence than the group of 16 to 24 years old. So we still have a lot of things to do with prevention. For the participants' mental health, participants who are above 24 years old screen for mental quick screening tool for the mental health issue. We see that the positive score among them is 58%, and for the young participant is 21%. The high-risk sexual behaviors, with the identify risky sexual behaviors that we mentioned in our questionnaires are anal sex, irregular use of condoms, group sex, chemsex, hyphen, transactional sex, and we find that most of the clients, as you can see here, engage have more than one risk. For the clients with QSD positive, we see that they are more likely engaging in QSD positive means that they have symptoms of mental health issues. And that is also, we find that there is a correlation between that and the chemsex practice and group sex and transactional sex. There's also, we find the correlations between the adverse childhood experiences score and the age of the clients using substances. Clients with the, when they share that they first started using drugs before 16 years old, they have much higher score of adverse childhood experiences. Here you can see it's 3.9 compared to the clients who use drugs after 16 years old is only 2.75. So that means addressing the drug use issues among young people, addressing the adverse childhood experiences among young people is very crucial in the programming of harm reduction for stimulant drugs. We also see changes after the counseling sessions, after the group-based activities. We see that there are changes in some behaviors among the clients, including the first one is the condom use. Is the percentage of before and after intervention increased from 15% to 27.6% of frequent condom use among the clients. However, chemsex and group sex both increased, and we identify that the reason for that, we did some qualitative interviews with the clients and will share that they are not able to share in details about their sexual life with outreach workers when they first come to receive the service. But later on, when they are more familiar, after more than 6 months of receiving the service, they are more comfortable to share. That is the reason why the percentage of clients reporting on chemsex, hyphen or group sex increase after the intervention. But we also identify that this is one of the issues that we need to address in our programming. this is when we ask the client with the assist to the number of the clients reported of reducing the drug use, and there is with when we screen with assist, there is also decrease after the interventions. So that is a very good sign that we are able to provide the counseling for reducing drug use. We also notice a change in the score of the pre-screening tool for mental health among our clients. The percentage of positive score was reduced after the intervention significantly. We also refer our clients to diagnosis and treatment at the hospitals. And these are some of the numbers that we can share with you. The psychiatrist's most common diagnosis for the clients who use stimulant drugs that we refer to the hospital. Majority have anxiety, 21% have psychosis, 13% have depression, and 23% are other diagnoses. So in summary, there is strong evidence of correlations between substance use, mental health, HIV, and high-risk sexual behaviors that we need a comprehensive prevention program, intervention and prevention program for them, and not just HIV. We see that mental health is one of the key issues among the clients who use stimulant drugs, that if we left it out, the services will not meet the needs of them. The age of first drug use is getting younger, so prevention for drug use also should be in place. And all of the interventions that we share in this presentation are community-based. Without the outreach workers, without the people who understand their clients the best, it will not work. For example, mental health is one of the issues that we identify is the key things among the clients. However, we are not able to communicate about mental health to them, but the outreach workers can. They are the only one who can destigmatize mental health. They are the one who sensitize their clients that mental health is not being mental, being crazy, but this is normal issues for even other people who don't use drugs. And getting help, getting treatment at the hospitals can help you to better your conditions. So they take the clients to counseling at their office, and then take clients to the hospitals to get treatment. And because of that, our program works. So we highly recommend community-based intervention models, but also with the linkages to the professionals' health services. And that's it for the sharing from SCDI. Thank you so much for listening. And if you have any questions, you can come to our website or write to me on email. Thank you so much for listening.
Okay, thank you. Now we may open the floor to question. Any questions, comment? Yes, please. ขอไมค์หน่อยครับ
Thank you. That was very interesting. I was wanting to ask Pascal. We often talk about giving safe smoking kits or to people using drugs as a harm reduction. And you mentioned, but the most difficult thing is the law in these countries. And I'm very interested in Indonesia because you said that even though it's illegal, there was some kind of understanding, and we can explain how that works. Is it really, can that become, in Indonesia, has that become accepted by central government, or is it only a very local use? And then secondly, is there only one type of pipe, or there are multiple types for different types of drug use? Thank you. And then also to Eleanor, I think that also very good presentation. But I think Singapore is so strict. The people coming to the center, do they have to be very careful of not being seen by police or identified? People in Singapore using drugs, are they also seen as a crime in using drugs? And so thank you so much.
I'll let Eleanor, ladies first.
Oh, okay, thank you. Yeah, so to answer your question, yes, in Singapore, people who use drugs are criminalized by the law, so users are criminalized. For the greenhouse, though, because we work with the government, there is some kind of like understanding and support from the Ministry of Home Affairs and Ministry of Family and Social Development. So we do have the support, but in collaboration, we really have to adhere to a abstinence-based sort of program. So people who come through our doors are not monitored, like the center is not monitored in any way. We've got support in that sense, but we have to adhere to sort of like the broader like legal context of Singapore. Yeah.
Thank you for your question, Kun Prambun. That's, I think, very important point that I didn't have time to get into, so I'm very happy that you raised this. Specifically in regards to how the procurement was conducted in Indonesia, indeed, they received a special permission. So it was not codified into law. They were not able to change the law that still prohibits possession of pipes or other types of paraphernalia. But within several months of advocacy work in collaboration with the local police and with the Ministry of Public Health, they were able to obtain a special permission in writing that allowed them to initiate procurement. The procurement wasn't done through a centralized mechanism either, so they had multiple sites, and each site was sourcing their pipes from the local pharmacies. So ideally, it would have been better to negotiate and find a centralized mechanism for procurement, but they were in a hurry. They wanted to get the pipes out as quickly as possible. They knew that the pipes were available in the pharmacies. They had feedback from the clients that they liked those pipes, so they went ahead with small batch procurement within different pharmacies. So there were, yes, indeed, different types of pipes as well that were procured. So we weren't able to get the pictures from all the different types of pipes, but to my understanding, there were different models of pipes that were procured. So it's kind of like needle procurement. Ideally, there should be a personal preferences, a preferences assessment with the clients that's conducted, showing them the different models and seeing what clients prefer what types, and then calculating procurement accordingly. I hope that helps.
Yes, please.
Firstly, I'd like to thank both speakers for their very informative presentations. So I'm with the Thailand Institute of Justice. We have our own program with ex-offenders. The majority of them, of course, as was revealed in this morning's presentation by the Minister and by other speakers, are former drug users, or some of them are current drug users. So the harm reduction is something we're very interested in. I'd like to ask both speakers generally with regards to firstly, risk mitigation, especially with relapse. As you, especially Eleanor mentioned, that there's always a risk of relapse, and so it must be sort of continued cyclical support. Do you have any sort of information or on like relapse rates, and also what strategies can be implemented to reduce the risk of relapse? Will be my first question. And secondly, with regards to working and communicating with employers. So specifically when we have people who are, we're trying to put them through harm reduction, and one of the benefits touted in Eleanor's presentation was that we earn savings through the income they generate from being employed during that period. Has there, in your experience, both in Singapore and also in the projects you worked with in the three countries from Pascal's presentation, was there any sort of effort to or if there was, what kind of effort was made to communicate with the employers on the status of these persons? Were they aware? And if they were aware, what strategies were used to sort of bring them around to the idea of feeling safe with continuing to employ these persons? Thank you.
Thank you for your question. For percentage of relapse, I think that's something that we've always struggled to kind of measure accurately, because I always say, like, the moment somebody leaves the center and they decide to go and use, it's like that's like a data point. So I think that's always been a challenge in terms of how we want to measure it in a way that makes sense. But I can say that in terms of relapse, I guess what the greenhouse really focuses on doing is that peer support relationship is one that's very strong. So that communication and connection between a new client or somebody that's relapsed, they would feel in general more comfortable telling their peer supporter. The other thing also is that there's quite constant contact, so almost daily contact with your peer supporter. So if somebody drops off suddenly, there's also some kind of, I guess, like awareness that maybe something is going on with the client. And relapse is understood as, people come back, and I guess the most important thing is that people come back and there's no judgment whatsoever. With regards to working with employers, I think this is very difficult because of, like I mentioned, the laws in Singapore. So in general, it's like the greenhouse is this special space where, using drugs or having used drugs before is like accepted, people understand, but outside of that space, it's like, okay, back to business as usual under the Singapore laws. Like so it's very rare that I think, even in international companies, I think it's very rare that we communicate and help people understand, fully understand, because also they're working in the context of legal, like legislation. Yeah. Thank you.
Thank you for your question. It's very important and very happy that you raised this as well. I second many things that my colleague Eleanor has said. Specifically in the context of, well, first, I think that it's important to understand that drug dependence, and there's limited understanding of this, but the WHO, the World Health Organization, defines drug dependence as a chronic relapsing condition. So relapsing is to be expected. It's not something that is to be avoided. It's something that we need to get accustomed to and work with, not to try to eliminate or to try to hide. So having that openness, having that understanding that drug dependence is a relapsing condition, then that opens the door for better management when that happens. In the 3 projects that I presented, especially in Indonesia, there was a significant attrition rate. So many of the employees, especially the peer volunteers, left the organization after a few months because of a combination of their drug use, relapsing, as well as being under pressure and also being engaged with people who use drugs, right? So they were dealing with their drug use. They might have stabilized for a while, and then they're sent in the field to talk about drugs for 8 hours a day and to engage with people who are vulnerable with very little support. So that was the experience in Indonesia. From my experience, when I was program director at Population Services International here in Thailand, we developed a set of tools to help manage relapse and burnout especially among the peer workers. So the first thing is in any context, the ideal would be to develop strategies or tools to help mitigate the negative impacts of relapse. The first thing is to develop a recovery plan with the individuals for them to identify what the triggers are so that that is known, especially by the employer. We had hired a counselor on our team to provide psychosocial support to our outreach workers to help them identify those triggers, avoid them, and if they couldn't be avoided, then to provide them with the support when they did meet those triggers so that it would not lead to a relapse. We had also developed a standard operating procedure that helped and did trainings among our entire organization to sensitize people about the fact that relapse was to be expected and was nothing to be worried about. We provide, our organization, many organizations provide temporary leave and medical support for a bunch of different conditions, whether it's pregnancy or burnout. We paired relapse with burnout to try to reduce that stigma and to facilitate the employer to provide some compensation leave to allow people to recover from their relapse and then have their place at work be retained when they were ready to come back. So those are just some of the examples. I'd be happy to talk more with you about those in greater detail if you like.
Yeah, thank you. I think that the session highlighted that YABA harm reduction is not only possible, but it's essential. So now it's over. We are run out of time. Thank you for our speaker, and thank you for your time, everyone. I may now close the session. Thank you.